So, good afternoon, everybody, and welcome to the MedEClasses Journal Club. And this is an initiative which we have been doing earlier, and for the last some time it was not being done. This is part of our academic series, which lies to look into latest evidences with regards to pediatric endocrinology. And as we know that every year there are around over 1,20,000 articles which are published across the globe, and if we do not keep pace with them, we will get left out. And very important to understand that when we're looking at those articles as to how it should change our practice in a clinical sense. This is something which is what we would like to do. And we have got four very interesting articles today to discuss about, which cover various aspects, particularly about therapeutics of different aspects of disorders, some common and some uncommon, which we'll try to focus about that. So why do we need to do a literature review? And what we are looking at in terms of literature review is that we want to see whether the journal article that we are reading should be part of our clinical practice or not. So the key questions you will ask is whether the results that the article has published are really valid. Very importantly, they may be valid, but whether they are generalizable to our settings or not. So if you look at some data with regards to 780G, which show that there is a significant improvement in terms of diabetic outcome, but if your patient cannot afford it, then it may not be generalizable to your clinical practice. We also want to see whether that journal article really represents a new development or it is an incremental phenomena. So whether it is a 0 to 1 or a 1 to 2 sort of activity. So you want to say that if it's 0 to 1, then probably this is something which is path breaking and things will change over time. And ultimately, the aim would be to change your practice from that regards. All of you can go and have a look at our website, learning.growsociety.com, in which has got a lot of resources and courses related to pediatric endocrinology. We have got fellowship and postgraduate training programs. We do run a number of postgraduate lecture series. We also run the journal clubs and guideline reviews occasionally as well in that regards. And our publications are available along with our mobile applications. So today, Journal Club is interesting. We have got two of our fellows, Dr. Dhwani and Dr. Alappan, who will be talking about four very interesting concepts, I would say, not only just in terms of the papers, but also the concepts of using aromatase inhibitors in CDGP, a sort of a novel thing where we know that testosterone is the treatment of choice. We all know that for OI, bisphosphonates have been used for a long time. Now, whether there's a role of a new anti-resorptive agent is what Dr. Alappan will talk about. Then type 1 diabetes, everybody says, okay, insulin is the only therapy. Now, whether the newer GLP-1 receptor analog may have a conceptual role, this is what we like to build up, and whether a novel form of treatment of hyperinsulinism. So what we are looking here is four distinct conditions which have got clear-cut treatment options. And now we have got new options which can be considered in terms of therapy in that regards. So when we are looking at paper, and this is what I like you to do, is that when you look at a paper, is to really look into from four basic questions. Why was this study done? How was the study done? Whether the design was good enough? What did they find? And what was their impact in that regards? So we'll start off with the first paper, which is an interesting concept in terms of the use of denosumab, which is an anti-resorptive agent in the treatment of osteogenesis imperfecta in children. So we have got Dr. Alappan who will take over from here.
Good afternoon, everyone. Thank you, sir. So my first paper review will be on the safety and efficacy of the denosumab in the children in osteogenesis imperfecta. So this is the paper which was published in JCEM in 2024. The study has been done in China, and probably it was the first prospective comparative study using zoledronic acid as well as the denosumab and the comparative assessment regarding that. We all know that osteogenesis imperfecta is an intrinsic bone disorder involving the collagen, and this osteogenesis imperfecta usually causes various bony deformities, scoliosis, increase the fragility fractures in the children, as well as also some extra osseous manifestations like cardiorespiratory manifestation, loose sclera, dentigerous imperfecta. The incidence is like around 1 in 15,000 to 1 in 20,000. The major treatment protocol that has been used till now in osteogenesis imperfecta in children were bisphosphonates. There are two groups, usually in oral therapy, which is used in case of mild osteogenesis imperfecta, while the IV therapies or IV zoledronic acids were used in cases of severe osteogenesis imperfecta. Now, why do we need to have this denosumab to use in these cases of osteogenesis imperfecta? There has been shown that the bisphosphonates have very inconsistent effect in terms of fracture reduction, especially the fragility fractures. That means in the minor trauma, there is a fracture in the bones. This has been a meta-analysis that has been published, and it is showing the osteogenesis imperfecta. We use bisphosphonate, the bone mineral density were improved, but the prediction of the fractures were not consistent with the bisphosphonate therapy.
So is it because there are limited number of controlled trials?
Probably,
This is
sir.
a meta-analysis of only placebo-controlled trials.
Yes, sir.
So do you think there are a lot of placebo-controlled trials which are available with bisphosphonates?
I think the trials number was not so much in terms of.
Do you think it may be justifiable to have a placebo-controlled trial now in the setting that if you know that there is a therapy with whatever questionable logic is, they will improve the bone density, whether you will be justified in using one arm in which there is no treatment given?
No, I don't think, because the severity, if we see
This is a catch-22 situation.
Yes.
Suppose denosumab was the first compound and you know that it improves BMD, you cannot have ethically an arm which does not have any treatment at all. So that is the problem, I think, in that perspective. Otherwise, if you look anecdotally, it is going to be a much. So I think what would be a better design in these sort of scenarios?
Superiority or non-inferiority between two available treatment options.
So there is only one available treatment, which is bisphosphonate. What do you do? You can go by historical controls. So what historical controls used to have and how many fractures will come from? So I don't think there will be a lot of randomized trials.
Yes.
So just because you say that there is a lack of evidence does not mean that there is no significant difference, because that is why it is being used a lot.
And also, if our study, it has been a comparative study, we're not using only denosumab in this study. So we can also see whether the bisphosphonate is better in terms of using, in terms of denosumab. Also, there are some severe adverse reactions like fever-like reactions, flu-like reactions in case of IV zoledronics, where in cases of oral agents, the gastric irritation, gastritis-like events were much more. Also, we all know that the osteogenesis imperfecta is mainly initially classified by Silence classification, and it was 4 major subcategories considering the collagen disorders. But later on, there are some also autosomal recessive and X-linked varieties are there, the special types of osteogenesis imperfecta with advent of the NGS and the other genetic studies, which was not properly or well controlled by this bisphosphonates.
What, according to you, this is what they have written. According to you, what are the limitations of bisphosphonate? When you want something new, you want to know what is the problem with the old one. So what is the problem that you have with the old treatment?
Sir, if we comparison with the placebo and some, but
no, I'm saying that if something is going perfectly fine, if you say your thyroxine is doing very well in hypothyroidism, you just don't have another agent, levothyroxine, you start using some other alternative form. You have to have some reason why you want to alter. What is your thought process on that?
In terms of bone mineral, I don't think bisphosphonates are much lesser, much important.
So anything else? That's what I'm asking.
The IV, the need of
give IV
injections,
the risk of having hypocalcemia, the risk of having high-grade fever, especially with plamidonate needing multiple infusions on days, these are the limitations. So that will be a more important limitation on that.
So in these trials, who has been taken as the study population? This is the children with adolescents younger than the 18 years of age. With we had confirmed with one of the following inclusion criteria. The inclusion criteria are in 3 stages. If the child has a pathogenic gene mutation that is detected by NGS or Sanger sequencing, if they had a family history of Y with associated features like blue sclera, dentigerous imperfecta, or they have at least one fracture with minor trauma. Now, they have described this minor trauma by that if we have fracture when we are doing the daily activities or fall from the height that is lower than the sitting height. In that scenarios, these children has been included in this study.
What means is that even if they have just one fracture and their Z score is less than -2, you will assume that they have osteogenesis. Because you don't have any other clinical features, you don't have any genetic diagnosis.
But at the same time, you have to think that, sir, this is due to the minor trauma. With minor trauma, if there is
Any
fracture is present.
pathological fracture, you will say it's OI.
No, we will not say this is
So
why.
this is what the diagnostic criteria is suggesting. Because if you go by your listing, any one of them, history of at least one fracture and is a pathological fracture. Single pathological fracture, then and Z score is less than -2, you say it's OI. You're assuming every low bone mass is OI.
This paper has.
So this is one. So this is how you have to critically look into it. Carry on.
They had also excluded some children in whom BMD cannot be measurable at the level of the femoral neck, lumbar spine, or hip. Also, the patients with renal failure, and also any current treatment protocol that causes this inhibition of the bone resorption that could bias the result of this study has been excluded from this study.
It doesn't even exclude the other possible causes of low bone.
Yes, sir.
So these would be part of the limitation that you have to start off right away. So when you look at the article, you have to look what are the issues to go ahead. How did they define OI? But at the end of the day, you're not talking about low bone mass in children. You're talking about osteogenesis imperfecta as a specific trial. So that becomes important. Can you?
Now,
because 2 and 3, so either you can say 1 plus 2 or 3.
Yes, that could burn me. Yes, sir.
So that will become easier one.
Now, this is an open label randomized controlled trial having 84 children. They had been divided into two groups. One group is denosumab group, that is consisting of 42 children, and another group is zoledronic acid group, that is 42 children. And they had done 6 monthly and 12 monthly follow-up for a 1 year of duration.
But before you go ahead, you should say what is the advantage of denosumab for people who are not aware about that over zoledronic acid.
Yes. So denosumab is a rank ligand inhibitor. So when we are using this, it is inhibits the bone resorption in that scenario. Also, as we all know that bisphosphonates are getting deposited in the bones and staying there for the long time. Denosumab is a short-acting agent, so it will not cause much harm when we stop the treatment of the denosumab. As well as denosumab is given 6 monthly duration with a subcut injection.
That is the biggest advantage, that you have a subcut injection not requiring hospitalization.
Yes.
That will be the biggest one. Now, what you said that it is not deposited in the bone and the shorter action, whether it is an advantage or disadvantage is a open case. You cannot say that that's an advantage. So I think the biggest reason why adults are moving towards that is that you have to give subcutaneous injection once in 6 months. So carry on.
So in the 1 year of follow-up, the denosumab group has discontinuation of 11 children, where there is only 2 discontinuation in the group of zoledronic acid, and among these 11, there is 6 patients who are discontinued due to the hypercalcemic crisis or hypercalcemic like episodes are there. Now, if we see the baseline characteristics in this study, the male-female ratio was 2:1 in both the arms. The mean age of in the both groups were very much comparable in that scenario. If we see the anthropometric measurements, also they are comparable in the both the groups.
So why have they not given p-values to compare the two? So when you actually have a good randomization, you don't need to show that the p-value is not significant. You assume your randomization is there and you don't even need to look. It's just that if you find a bias, you can look at it. Otherwise, you assume that there was a proper randomization there.
Okay.
What do you see particularly here, which is not similar to a typical OI cutoff cohort? What is unusual here?
The BMD scores.
So you said BMD score is, where is the BMD score?
So not significantly lower in cases of lumbar spine actually.
There are two, three big things that we're looking at. One is the age.
Hmm.
What is the usual age of presentation of severe OI?
Very early onset.
So it will
It's
be
very
typically in
Hmm.
infancy.
Hmm.
So it is very, very unusual that your age is 7.35, 7.5. So these are very, very late. So
Hmm.
it may be either they are taking milder cases
Hmm.
or whether these, and were these cases treated earlier also with bisphosphonate or not?
Yes, they were treated.
So this
Yeah.
part, so they have not excluded patients who were not treated. These are not drug naive patients. Number one. And number two, what you're seeing here is that they are older. And now if you look at the BMT Z score,
Of lumbar spine, that it is not so less as in comparison to the osteogenesis imperfecta. Minus 1.5 and minus.
but your first criteria is less than -2.
Yes.
So that is the whole problem in the criteria.
Hmm.
So one side they say low bone mass and fracture is the one. Second, they say they just have a eye sign and they don't even have fracture, they are over.
Yes, there are no fractures, but only family history was present there.
So this is like in a very, very dichotomous group of population. Which means if you have loose sclera and you don't have a fracture, your bone mass is +2, you are still over.
They assume that they are boy actually.
Yeah, so that is a problem I would say in terms of the inclusion criteria. And that's reflected, which you also pointed out, is that if you look at any of these Z scores, you maybe femoral neck Z score is on the lower side.
Yes.
That is there, but otherwise the BMT Z score is not exceedingly low. So I think that is something which is important. Now, if you look at previous fracture time, which is 4, which is reasonable. Okay, and 14 and 19% had used bisphosphonate.
Yes.
This figure becomes important. Why? You yourself said that if you use bisphosphonate,
There is increased risk of fractures will be much more.
they would be there for a long time. So it may be interfering or it may be augmenting the effect of other therapies.
Yes.
So this is something you have to worry about, carry on. But of course, if you look at that way, you've got 42, 42, 80, 4 patients of OI, it's a big number.
Yes.
So you have to think of that it's a good study, but then you have to think of what could be the thing which can influence the results also.
Ideally, on the genetic study, we should be confirmed the genetic study.
It
Then
should have been, if you ask me what should be the criteria, these will be drug naive, novel patients of OI, diagnosed, confirmed using genetics. Because when you're doing so much, you should be very, very clear that they are there. And then those OI patients must be candidates for treatment. Just having the gene and your bone density is in the normal range doesn't mean that they need to be treated. So a drug naive new patient who is genetically proven, who has a pathological fracture. That should be done.
In the genetic study, they had done almost all the genetic study in all the patients. And in denosumab group, 8 patient doesn't have any significant mutation of the OI.
Yeah. So
and in 4 in zoledronic acid. So total 12% were there who doesn't have any.
Their first criteria is very vague. Second criteria is also vague. So I think that's okay. Let's go forward on that. So what they're basically saying is that there is a milder form of bone disorder that we are seeing at, and these are older children and they have received treatment.
Yes, sir.
So these things you have to take care of. Yeah, carry on.
Now, coming on to the first primary endpoint, that was a comparison of the BMD, aerial BMD, in cases of both denosumab group as well as the zoledronic acid group. It has been seen there is an improvement of, and that is a significant improvement of the BMD in both in lumbar spine, femoral leg, as well as total hip from the baseline in 12 months duration.
What statistical tool did they use to find this difference?
Statistical tool.
Which one will you use? If you have same person and you are seeing in 3 months, 6 months, 12 months, this is what you're doing. So which tool will you use? Yes, analysis of variance, not pair, one-way ANOVA and two-way. So ANOVA would be repeated measures ANOVA is what you will be looking at. So this will be ANOVA sort of a test you're looking at. Carry on. So
Uh,
what you are seeing is that there is improvement
yes,
in terms of density.
in terms of density, there is improvement in the from the baseline.
And how long are they following up for?
They have followed for 1 year. Total,
Only one.
1 year, only 1 year.
It is too less, but yes, okay, you're finding a difference. Carry on.
And also they had seen, if we compare the both the groups, the zoledronic acid group and the denosumab group, the zoledronic acid group has a significant higher bone mineral density from comparison to the denosumab group.
Okay, so yeah, so both groups are there. Okay, and carry on.
Now they compare the secondary endpoint there, that is the biochemical profile of the bone metabolism indexes, and they had shown that the calcium level was much more higher in comparison to the baseline after 12 months of treatment with denosumab, but there was no significant change of calcium level in cases of bisphosphonate therapy. Also,
It went down a bit.
but I think there is some mismatch with the color coding with denosumab and zoledronic acid in this study.
Okay. Now, do you think this is a good way of showing the calcium results?
I don't think, sir, this is a good way because this is only a 6-month study, a 6 months
What are
value.
you more interested in? The average calcium or how many are hypercalcium?
Ideally, it should be how many are the
How many are
hypercalcium.
hypocalcemic? So if you could have shown the distribution that these percent is normal, it's like you say time in range, time below range, time above range. So calcium in range, calcium below range, calcium above range. That is more important. Because if your calcium, somebody's calcium is 20, he will drag the entire graph toward the upside. So this is not a very most important thing to look at, but yes, you can here also see.
But sir, also you can see the
and what you
baseline
see
to
here,
the.
that there is a wide skew in the calcium level in the denosumab group, because those who have more calcium, few individuals are dragging it away on the other side. But the mean value is not that high.
That high, yes.
So yeah, so what you are saying is that there is different differences in calcium. What about other parameters?
There is a decrease in the bone resorption markers, that is beta CTX level, and also there is a significant change of ALP level both in the zoledronic acid group as well as the denosumab group.
So they have come down.
They have come down.
ALP level has come down.
ALP level has been come down. Now the one more important thing here is that there is much more incidence of hypercalcemias, and 6 patients almost
that
having.
Is the most important. That's what data you want.
Yes, the hypercalcemia was after the discontinuation of the denosumab therapy was done, and it was 13 in numbers where there is no episode of hypercalcemia in cases of zoledronic acid group. And among these 13 patients, 6 patients was critically ill. They have to admit in the hospital.
So
for
when
the
you say
treatment.
discontinuation, it means was it even after the first injection, second injection, or after the third injection?
Even there is only 2 injections given, 6 months and 12 months. After the 12 months,
0 नहीं दिया.
3 injections total, 0, 6 and 12 months. After the 12 months injection, the mean duration was 4.7 months after the first hypercalcemic episode has been noted.
So the hypercalcemia happened after you gave the
third injection. Yes.
And after 4 months.
After 4 months. Mean
So what I'm asking is that, did it happen between second and third injection and first and second also?
There is no such data about that.
6 months, it is within that therapeutic period. So it should not have happened, because by this time the denosumab should be working. So do you have the timeline for that?
No, sir, I don't have any timeline.
Okay, carry on.
But sir, one more thing important, that the duration was 6 monthly interval, and I am saying that after 12 months, after 4 months, the mean age is 4 months. So even if it happens, it should be happened between in the 0 months and 6 months, or
Yes,
6 to 12 months.
It should be after 18 months. Hypercalcemia effect, all this rebound effect should be happening after 18 months. Now, first of all, why does denosumab have a rebound hypercalcemia?
Because this is very short-acting molecule. It acts on the rank ligand. When we taper it off, there is no effect present, and there is increased bone resorption starting.
Bisphosphonates not only stop resorption, they also kill the osteoclast.
Yeah.
It has got no effect on osteoclast. So osteoclast gets suppressed, but they are not killed. As soon as you remove it, they will surge again. But as you said, the effect should be at least there till around by the time denosumab is there.
Hmm.
So this 16 months seems to be a bit of a concerning thing,
Hmm.
which means that in younger age group, the 6 month period is not good enough to
Hmm.
provide enough suppression, because maybe the rank ligand activity is more, its
Yes.
recovery is better than your 0 to 6.
Hmm.
6 to 12 also may be a risk of hypercalcemia.
They had pointed out the similar thing, and they also mentioned that the dose of the denosumab they had given to the hair, it's not on the weight-based dose. They had given above 5 years 60 milligram and less than 5 milligram 30 milligram denosumab. Huge dose, and also, sir,
60 is for adults.
yes, they have used that dose, and due to they have said that if we use the weight-based dosing formula, maybe that we could prevent this kind of hypercalcemic episodes.
Yeah.
Now, they has also looked for the vertebral morphometry or the risk of spinal compression fracture, and they have seen that the average projection area as well as the ratios of mid height versus limb length, lower length ratios were improved in both the cases of denosumab and zoledronic acid, but it is significantly improved in cases of denosumab group. All
But you have to tell us what is the meaning of this.
Yes. They had now I first describe how they have taken.
What is the meaning of these values for a patient?
Hmm.
Are you happier with a higher PA value or a lower PA value? What does it mean?
If the PA value is higher, the projection area is higher, there is less concavity. This is concavity index basically. So there will be less compression, less chances of fracture, spinal compression fracture, and increased chance of height gain also in that scenario.
That is what we could
Hmm.
point to that. So there were vertebral benefits in both, possibly more in the case of denosumab.
Yes. Also, they have seen the height gain in these children, which was almost comparable in the both group, 5.6 versus 5.7 centimeter, which shows that there is no incidence of any vertebral fracture or in this scenario. Now, in comparison to the adverse effect, we have the zoledronic acid is known to cause various febrile illness, which is very much prevalent in our study also. There is 30 patients that has been presented with acute febrile illness. But when you compare the hypercalcemic episodes or the hypercalcemic crisis, the denosumab group has much more hypercalcemic events in comparison to the zoledronic acid. And the interesting thing about this thing is that there is no episodes of hypercalcemia seen with this case of zoledronic acid. Even the patients presented with hypercalcemia also treated with hydration and zoledronic acid, who were subsequently normocalcemic for the 1 year of duration.
So what do you expect with zoledronic acid? Hypo or hyper?
Not hyper, hypo.
If at all, if you have a low amount of calcium status, you will develop hypo. But hyper, it's a treatment of hypercalcemia,
Yes.
so you will not expect hypercalcemia there. Yeah.
So they had concluded that the treatment with denosumab have significantly changed the bone mineral density as well as decreases the risk of spinal fracture in cases of pediatric population with OI, and the effect is almost similar to the zoledronic acid. Though there is increased risk of adverse effect in these cases of denosumab group, they had concluded that the younger age and the high bone resorption markers in patients who have younger age less than 5 years of age and high bone resorption marker, they have much more risk of hypercalcemia rather than the rest of the group.
And the irony is that they use the older age.
Yes.
And milder cases. So if they had done in younger age, it would have been more devastating. So what does this conclusion tell you about? Would you use this in your patients?
No, we will need proper OI subset to study the role of denosumab to actually know whether or not we can accept it in our practice.
No, and if you study the answer, what they're saying that you're comparing drug A with drug B, and then you can say, okay, drug A has got side effects, but drug B can help in you getting those side effects better. So why should I use drug A? I should directly use drug B. So clearly they are saying it can be alleviated using zoledronic. So what they're trying to say, okay, use denosumab. If you have hypercalcemia, use zoledronic acid. So why should we use it in the first place is something which is clear. So I think this is a very, very clear study that this is a new way of thinking of it. The drug has been developed. Now they're trying to find its indications. This is a very well established drug in adult osteoporosis.
Yes.
But I think there are so many things. Probably there is not much pharmacokinetic dynamic data in children. Maybe it's not working for 6 months. So it's too premature a trial which has been done. So carry on with the further evaluation.
So this is a prospective open label randomized controlled trial. The monitoring we did here using the DEXA scan and also the biochemical parameters of like calcium, alkaline phosphatase, PTH and phosphorus. And the population was taken was children and adolescents less than 18 years. Now, whether it is a generalizable or not, the children has been taken with children and adolescent at osteogenesis imperfecta, but there was no definite proven osteogenesis imperfecta in our inclusion criteria. And the intervention is feasible, but we need to be much more cautious in terms of this hyperglycemic episodes. Also, the dosing interval we using in the children. The major limitations I found in this study was that the dosing must be in the weight-based formulation, not be generalizable one. And the dose interval should be also be considered whether we can use 6 monthly dosing or a much longer dosing in that scenario.
So the basic concept is you give a high dose, doesn't matter, you are suppressing. A bit like GNRH analog. So they are going in that direction. So they are saying more will not cause any harm. So let's keep a high dose. Like 60 milligrams is a huge dose. It's an adult dose. And 30 milligrams, let's say for a younger child, will be a big dose. So carry on.
And the study duration was not so longer, around 1 year of duration, and there was no frequent monitoring of blood calcium levels. So we may have missed some of the asymptomatic hypercalcemic episodes in between them also. So these are the limitations in this study. So it has significantly improved the bone mineral density as well as the vertebral morphometry with some adverse effect. And right now, we think we should not recommend to use denosumab in the children until there is some much more important RCTs present in our hand.
I think that's a very good review, and I think this is a good message that everything new is not going to be something which would be followed in all the scenarios. Thank you, Alapan. And this really is an interesting molecule. A lot of work is being done. Now, recently, sclerostin agonist has already been approved in adults. It's available now. Romosozumab is available. Now, it may take some time for it to come, but that will be an anabolic therapy. So that will be a positive way to go forward in terms of evaluation. We'll see if there are any particular questions regarding this particular thing. There are, I think, few questions. In some study, they mention hypercalcemia after stopping denosumab. Yeah, so it is basically after stopping denosumab only. That was around 4 or 5 months later than that. That was the cause on that perspective. So now we go to another very interesting thing. We have been treating tons of constitutional delay of puberty and growth with lots of testosterone injection. That's a standard treatment which is being done. Now, this seems to be a counterintuitive therapy of using aromatase inhibitors for pubertal induction. We know that aromatase inhibitors have been used to increase height, increase the duration of growth. But of course, when you use aromatase inhibitors, your testosterone may go up, your feedback inhibition of LH-FSH may go down. So whether they can be a good way to induce puberty in boys, we have Dr. Dhani who will talk about this interesting concept.
Thank you, sir. So moving on to the second case, second paper for review today. We have the study looking at letrozole versus testosterone for promoting endogenous puberty in boys with CDGP. This was published in the Lancet Child and Adolescent Health in 2019. So why did we even think of trying a new drug? So we know that CDGP is a common clinical presentation in our day-to-day practice where we are often at crossroads of how to go about whether or not to treat such patients. So the current treatment options are watchful wait, and in children older than 14 years, a course of testosterone therapy given intramuscularly may be given for 3 to 6 months, especially in those who are more apprehensive about this delay in pubertal progression. So the ideal drug for pubertal induction in boys is something that promotes androgenic signs of puberty, increases your testicular volume, increases height with minimal epiphyseal maturation, is easy to use and has no side effects, right? Testosterone works by the following two important mechanisms. It increases the free IGF-1 levels and thereby increasing the growth velocity. Also, because your testosterone will be aromatized to estrogen, it will promote skeletal maturation in boys, which will in turn trigger your central pubertal process. So while testosterone promotes your androgenic activity, it will cause skeletal maturation and ultimately trigger central pubertal process, increase your testicular volume. It will increase your height, but again, it also slightly increases your estrogen levels. So that is one thing where your testosterone may have a small shortcoming. Intramuscular use makes it a difficult option and a not readily acceptable option for patients, and it is associated with side effects in forms of priapism and some aggressive behavior in the short term. So the search for alternative brought to us the treatment of aromatase inhibitor, which was being used for CDGP boys, especially those in the mid-pubertal range, to gain added height benefit. So aromatase inhibitors, the primary action is prevention of aromatization of adrenal and testicular androgens. So your androgen levels will go up, your estrogen levels will be lower, thereby delaying skeletal maturation. It has also been shown to have a direct stimulatory effect on the HPG axis, promoting your central pubertal process. And the best part about aromatase inhibitor is an oral route of administration.
So when you talk about CDGP and treating CDGP, if you think of thinking it as a pathology, what will be the most physiological treatment? So what is the basic problem in CDGP and what is the most physiological treatment?
The most physiological treatment would be something like a GnRH therapy.
So you can have some GnRH pulses which are being formed and that can cause a treatment from that regards. Testosterone is also the second most physiological therapy. So ultimately you have testosterone deficiency. So you are replacing testosterone and that's how it's working. Aromatase inhibitors, do you think it is a physiological way or a pathological way without looking at results?
No, it's not a physiological.
So what is it doing?
It's basically it's inhibiting the aromatase, so the testosterone conversion to the estrogen is not happening. So if there is less estrogen, the skeletal maturation should be lesser.
So that is a different thing. But how is it inducing puberty? So what it is saying is that whatever testosterone is there is not getting converted to estrogen, and therefore your levels will go up. When other thing is believing is that in that regards, once your estrogen is low, and estrogen may play a role in HPG suppression, that also is not happening, and that is how it is working. So now, if you talk about that testosterone deficiency, you are giving testosterone from outside. GnRH deficiency, you're giving GnRH from outside. Here, you don't have a estrogen excess.
Yes.
That you are blocking that estrogen. So that physiologically, this is not a correct way, I would say, from that regard. So whatever the effects is, but if you talk about physiology, you are blocking an enzyme which is there in the body for some reason. Why would you have aromatase if it was not required? Now, which are the tissues in males which have got aromatase expression?
So tissues in males that have aromatase are the bone epiphysis, the
So bone epiphysis or anything else in the bone? The osteoclast, they also, so not only the growth plate, but also the proper bone, I would say.
Yes.
Yeah, then
the adipose tissue will have
Yes.
aromatase activity.
Prostate,
Yes.
testis, brain. So nearly there is a universal expression of aromatase and estrogen receptor in peripubertal males. So just that estrogen may not have a role. We don't know what's the role in the paracrine or autocrine effect. So all those parameters we have to consider that. So if you just talk about physiology, this doesn't make a physiological sense. You're trying to do a convoluted thing. But let's go forward from there. What did they find?
So your aromatase inhibitor
And when you
means
think no side effects, that's an assumption.
yes.
So that's an assumption because this is a drug which has not been used for a long time. And if you say testosterone priapism, that is a very, very rare scenario. So there are definite concerns about aromatase inhibitors which have been shown, particularly with regards to the bone health, with regards to vertebral morphology, with regards to adiposity, with regards to prostatic health. So all those things are there because if you talk about aromatase deficient individuals, they have been found to have low bone mass, males,
Yes.
and they were found to be infertile, and so a lot of things are there. So this is more of an assumption on, and then you're giving a daily drug.
Yes.
So these are all issues there. You carry on.
So this was a randomized control open label trial conducted in Finland. It included boys with delayed puberty who were older than 14 years of age. The inclusion criteria included a testicular volume of less than 4 cc and a serum testosterone of less than 5 nanomoles per liter. Later on in the study, they also included children with Tanner stages 2 and 3 with lower serum testosterone levels. The exclusion was any pathological cause of delayed puberty. So definitely they looked into anosmia, synkinesia, all the causes of pathological puberty that may cause a more permanent cause and not CDGP. And they excluded children who were on drugs that had any implication on their pubertal progression. Supportive tests to confirm or exclude CDGP were inhibin B and GnRH stimulated LHFSH levels. We've not really described it. So the study was, the sample size was detected to detect a 3 ml change in, was powered to detect a 3 ml change in testicular volume, and it came out to be around 22. They ended up recruiting a slightly more number of subjects. Of the 35 subjects who were eligible for the study, 5 opted to go for a waitful watch. 15 were enrolled in the letrozole group and 15 in the testosterone group. Now, the letrozole group received 2.5 milligrams of the drug daily for 6 months, and the testosterone group received 1 ml per kg roughly. So they made very strict weight-based testosterone dosing, and so that there was standardization in the dose of testosterone that the children received.
If you compare this to what dose we use,
so it is very similar to what we use, but we do not usually go beyond 50 mg even for pubertal.
CDGP we often give 100
Initial.
milligram 3 months.
Initially.
Initially also.
Yeah,
So
okay.
this dose seems to be a bit lower because most of our boys will be like 50 kgs roughly, let's assume, we will give 50. But many of them beyond 14 when you are inducing puberty, 50 is a very low dose. We use 25 for less than 5 years, 6 years. When you talk about micropenis, then we go to 55 years, 7 years and beyond. So this dose, maybe they are standard, but it seems to be a bit less compared to what we are using. That would be my comment on that. Yeah.
So these children, the intervention was done for 6 months, and then the children were followed up after the after stopping the intervention for 6 more months.
And they give 6 injections.
Yes. So testosterone was given 4 weekly injections. Both the groups had similar age of the population, similar testicular volume, bone ages, predicted adult heights, estradiol, inhibin B levels at outset. And what they
Let's
found.
go back to the inhibin level. So inhibin levels were pretty good. They are well into that range, and testosterone levels, nanomole per liter, were also not that bad. Okay, but LHF, they were really, it's very difficult to say that they were really delayed.
Which is on the bottom.
It's pretty much in the
Pretty
metabolic
much.
range. And
Cholesterol is also high.
But there was no clarity whether these were basal or stimulated levels.
must be basal.
Basal.
So this is basically most likely children who are very close to entering puberty anyways. But yes, they are 14.8, so it's a bit dicey. Carry on.
So what they found, their primary outcome was a change in testicular volume, LHFSH testosterone levels, and inhibin B levels. So if we first look at the testosterone levels, what we see.
LH.
Okay, so this is the graph showing the testosterone levels, and as we can see, the levels were higher in the aromatase inhibitor group compared to those who received intramuscular testosterone during the period of intervention. However, after stopping the intervention, the levels were comparable in the two groups. Similarly, if we look at the LH levels, we see that there was a slight dip in the LH levels after the first injection with testosterone. However, aromatase inhibitors showed higher LH levels during intervention arm, and finally they both ended up having the same LH levels after stopping the intervention. Similarly, for the FSH levels were higher with the aromatase inhibitor group. And if you look at the inhibin B levels, they were slightly low at 3 months with testosterone. However, the final levels were comparable in both the groups. Looking at the testicular volume, it was shown to be higher throughout the course of intervention as well as post-intervention in the aromatase inhibitor group compared to the testosterone arm. And as would be expected, estradiol levels were slightly higher, but not clinically significant in the long term with testosterone arm as compared to aromatase inhibitor. The IGF-1 levels were, however, found to be higher at 6 months with testosterone in comparison to
If
aromatase.
you hold on, this gives you a very good physiological perspective at least. So even if you don't think about this study, you can think of what physiology does. So what you are seeing here is that when you give testosterone, LH level went down because this is obviously a direct suppressing effect of testosterone. It gets aromatized and get converted. FSH went down again, the same scenario. Inhibin B dipped.
Yes.
Which was again, so all this is because of decrease in FSH basically. Decrease in FSH causes decreases in inhibin. Now, what you are seeing here is the testicular volume. There was a steady increase with testosterone. And estradiol levels, of course, will go up when it's getting aromatized. And IGF-1, because they are estrogen dependent, they are on the higher side. So simply saying that when you give testosterone, it is aromatized. If you give too much testosterone, you're going to suppress your LH, FSH, which will bring down your inhibin B. Testicular volume will take some longer time to grow, and your estrogen levels will, in a way, falter, will increase, and the IGF-1 levels will basically increase. When you use aromatase inhibitors, you are knocking out estrogen, inhibitory effect on LH and FSH. So LH and FSH are going high. That's why inhibin B is also going high. Testicular volume is jumping up because you're giving LH and FSH on the higher level. So both are increasing. But the problem is that IGF-1 level may dip to a greater extent. So this may offset any significant advantage. So if you now look at about this testicular volume, what do you really think about it?
So again, it does tell you that in the short term, aromatase inhibitors do give you a better testicular volume, but we do not know the long term.
And what you're saying that there is a
effects.
very rapid rise.
Huh.
It's a bit like you are giving an insulin bolus rather than an insulin infusion. If you look at the graph for the testosterone group, it sees a linear increase. So there is an increase happening quickly, and then it is in a way stabilizing on that. So this may be now whether we think it as advantageous or disadvantageous is also important, because when we talk about pubertal induction, we talk about something which is gradual. We don't want it to be too, because ultimately what you are seeing at the end of the day, your LH is the same, your testosterone is the same, your FSH is everything is the same. So whether you reach there fast or you reach it slowly, that is the only difference. So that is a point on that.
Height, should there be any?
Height is not shown.
I will come to it.
Yeah.
And the secondary outcomes looked at the growth velocity and lean mass and bone mineral density. So if you look at the growth velocity, it was just short of being statistically significant at 6 months with the testosterone arm. However, overall, if we look at it, the testosterone arm does perform slightly better, but the difference was clinically not significant. The bone mineral density parameters.
The numbers were too small to give you any idea about the height. So if you now look at the thing, this was basically based upon testicular volume.
Power to.
But to height, you will need a bigger number. So this is very clear that even with smaller numbers, testosterone is doing good in height. Now this will be an important question, whether this will be an effect on final height or not.
Yes.
That will be a question to go ahead.
So
Density.
Bone mineral density and lean mass parameters fared slightly better with the testosterone arm compared to the aromatase
My major
inhibitor.
problem here is that this study is not designed to study these
Yes.
parameters. You will need much higher sample size on that. So just because you don't see a difference, you cannot say that this is safe from that regard. Because the only thing that you're looking at is testicular volume
Yes.
increase. Yeah.
The incidence of adverse effects was reported to be similar in both the groups, especially looking at the musculoskeletal GI symptoms, fracture risk in the short term that we studied these children in. And that is how it is. So the study concluded that the letrozole might be a feasible alternative. However, if we were to evaluate, so this was a prospective study with no blinding done. The definition of CTGP used by the study matches pretty well with us, but the hormonal levels are definitely much higher than what we see. Even the testosterone levels are much higher.
In those cases, we may have waited and watched also.
Yes.
So you carry on.
And the population is very similar to what we might encounter in our day-to-day clinical practice. So the subjects are definitely generalizable. However, they may or may not warrant treatment at the time of intervention that was done in these children. So the impact of this study, I would say I would have a neutral or more guarded.
See, my only concern that you're having that rapid bump in testicular volume. Somebody who is at around 2.5 ml becomes 10 ml very quickly. And then he remains 10. So now what is going to happen in terms of long term, whether you are exposing if you put it, how do you put it? You can say that you are exposing that testis, which may not have matured enough to a very high level of local testosterone.
Mm.
While with systemic testosterone therapy, the exposure is not that much. So this could be a bit of a concern. So what you're doing effectively, you are inhibiting estrogen, you are increasing your LH level,
Yes.
and you are increasing your FSH level. So you are in a way giving HCG.
Yes.
In a way, you are giving HCG to the patient, roughly if you can think of it. So we know that if you give too much of HCG or you cause too much intra-testicular testosterone levels, it may cause a bit of a concern. So unless we have data which tells us what happens in the final height in terms of long term, in terms of their fertility, I would be very guarded. And testosterone therapy has been used for a long time. I think more physiological would have been to, okay, you say that I'll give GnRH for some time, which is not of course possible. Nobody will do that because it will be too expensive. But I think without that, testosterone itself is a good enough one. And you were talking about oral testosterone.
I could not find.
So oral testosterone is mainly for maintenance therapy. It's not good for induction of puberty or for CTGP.
So again, as Sir said, existing options of watchful waiting and testosterone have been found to be safe, well accepted in clinical practice, and the incidence of complications with testosterone are also extremely rare, about 1 to 5%, making it a fairly safe treatment. And you're giving it just once a month, so compliance is fairly good with testosterone therapy. The long-term benefits of aromatase inhibitors cannot be generalized from the given study. And again, the long-term benefits as well as side effects. So, as Sir said, that aromatase is likely to increase your intratesticular testosterone. So that we have no data on the final height of these children, whether aromatase, because of its estrogen reducing
estrogen is known to play a very important role
fusion.
in fluid absorption. In the I'm talking about
Okay.
fertility,
Okay.
fluid absorption, spermatogenesis. So there are a lot of issues and prostatic hyperplasia. So these are known effects of estrogen. So if you remove estrogen, you may be worse. If you have too much testosterone, that's why the animal study that I did showed prostatic hyperplasia. Because if you have too much testosterone in the prostate, you will have those problems happening. So it's not a very physiological way. It's basically you're trying to do the other way around. So I think it's too much of a jugaad therapy, I would say, rather than a real physiological replacement. But yes, you have to watch the space there.
Thank you, sir.
Thank you. So I think that was a good one. Now we'll have two slides. So we had a very good discussion on these two studies. One was about denosumab and the other one was about the role of aromatase inhibitor. Now there are two new agents which are not in the sense I would say new. They are something which is already established and they look physiological. So we'll quickly try to see what are the evidence about these agents, and then we'll go forward from there. So one is glucagon, which Alapal will talk again.
Thank you, sir. So this is the trial of a randomized control trial, phase 3 trial using dasiglucagon for the treatment of the congenital hyperinsulinism in children. This is the paper that has been published in JCEM in 2024, and the study has been done in USA using this dasiglucagon for the treatment. Now, why we need to have this in a new agent or a agent that is not used till now in the treatment of the congenital hyperinsulinism? So the first thing is that we all know that congenital hyperinsulinism is a very rare disorder with having an incidence of around 1 in 50,000 in population, and there are existing in terms of existing treatment, there are treatment like nutritional therapy, diazoxide, somatostatin inhibitors, and some uses some other agents like sirolimus also has been used. Now, most of these congenital hyperinsulinism are there is inactivating mutation of the ATP potassium channel is present, and the existing treatment in terms of the diazoxide that is very not well established in these cases. Also, many patients experience persistent of hypoglycemia and requires nutritional support even after treating with medicinal therapy. Not only that, even after the surgical therapy in terms of the near total pancreatectomy or subtotal pancreatectomy, there is 40 to 50% patient still remains hypoglycemic after that, and they sometimes manifest as severe disorders like diabetes. So we need to have something that can be change this kind of complication in the patient. So who are the treatment protocol who are the patients in this treatment protocol? They are infants of 3 to 12 months of age who had a following inclusion criteria. The body weight was greater than 4 kg with a documented diagnosis of congenital hyperinsulinism, and they were previously for 2 weeks they are given a blinded CGM by which and also SMPG to see there are more than 3 episodes of hypoglycemia per week. So these 3 criteria must be fulfilled before they are enrolled into the study. In the exclusion criteria, there are patients who has been treated with subtotal or near total pancreatectomy, and those patients who had developed or required exogenous insulin and had a HbA1c level of more than 7 has been excluded from the study. Now from this age group, from the coming on to the flow chart of this study, how this study has been done. This is a randomized controlled trial, using open label trial, which is done for 8 weeks of duration and has a long extension for another 4 weeks. So there were 32 children total present in our study, and which was randomly assigned 16 into 16 in the 2 groups. One group is given only the standard of care treatment for the first 4 weeks. The standard.
Tell us first, what is dasiglucagon?
Okay, so dasiglucagon is a novel glucagon analog that is.
So what is the novel about it? What is its half-life? Why are we using it?
I don't have much to say about this thing.
That is the main thing, because when you're looking, it's not just about the study. So when you are saying dasiglucagon, this is a longer acting analog of glucagon. There have been people who have used glucagon as pumps also for long-term control when there is a diazoxide refractory hypoglycemia preventing. So when is it used? When you want to prevent pancreatectomy. So somebody who is, of course, diazoxide responsive, you're not worried about that. But somebody who is diazoxide resistant, in that case, and you don't have a focal lesion, you need a total pancreatectomy. So people have used glucagon being delivered through the infusion pump, and that is going to then be giving you stable control. And what are the problems of glucagon injection?
there could be nausea, vomiting, like
nausea,
yes,
vomiting, rash may
like,
develop.
yes,
So
skin
like
rashes.
glucagonoma, if you look at, there are a lot of connected
Respiratory
rash
infections are much
which is
more.
there. So all those things are there. So this is the novel agent. So you need to really tell the audience about what really it does. Otherwise, how will they understand? So dasiglucagon is a longer acting, safer agent of glucagon.
So in the first group, they had been given the standard of care treatment for 4 weeks. In standard of care treatment, there is a nutritional therapy as well as diazoxide, and in some patients, lanreotide like serotonin, lanreotide somatostatin receptor analog has been used. And in another group, there has been dasiglucagon plus the standard of care treatment given for the initial 4 weeks. In the later half, for the next 4 weeks, all the patient has been shifted to the dasiglucagon and the standard of care treatment. And after completing the 8 weeks, they had been followed a long-term extension trial for the dasiglucagon and standard of care treatment. Now, so as Sir had already said, this is a novel glucagon analog, and in our study, it was started with a dose of a 10 microgram per hour, which has subsequently increased to up to 70 microgram per hour, and the major side effects were nausea, vomiting, skin reactions, and some respiratory illnesses that has been present in this study. So we compare the baseline characteristics of the patient in the both the group, and we can see the overall mean age was 4.3 years in cases of both the study. The male-female ratio was almost 50% with 16 patient in the male and 16 female patient. Height and weight were very much comparable in the both the groups. Now in standard of care treatment, as you can see that the somatostatin analogs and the diazoxides had been used, and also there is use of sirolimus in one patient in this study. Now coming on to the major hypoglycemic events that has been happened during this treatment. So it has been seen that initially for the first 2 weeks, the patient was put on CGM to see for the baseline level of hypoglycemic episodes that has been occurring or not. Also at the same time, patient was unblinded to the self-monitoring plasma glucose level. During the, we can see the self-monitoring plasma glucose level, plasma glucose monitoring incidence of hypoglycemic events were decreased in both the incidents, but they are not statistically significant. But when we compare with the CGM data, we can see that there is a statistically significant reduction of the mean number of hypoglycemic events per week in the as in the hypoglycemic events as well as in the severe hypoglycemic events.
So what you are seeing is that if you're doing SMBG, you are not picking up 75% of hypoglycemic episodes. So if you say there are 36 in the one with CGM, only 8 are there in the SMBG. So the SMBG should not be considered, I think, now.
Yes.
So what they're trying to say is that you are able to pick up more. So when you're picking up more, you will find more differences in that regards. Now, what is interesting is that as the duration of treatment went off from baseline to week 2 to 4. Okay, so 13.9 became 8.5 and 18.2 became 14.
Yes.
Yeah.
So not only CGM value has shown the significant improvement of decreasing the hypoglycemic events, also it has shown other kind of hypoglycemic, that severe clinically significant hypoglycemic episodes has been reduced. And also an important parameter was there was a decrease in the nocturnal hypoglycemic episodes in cases of CGM value in this study with dasiglucagon and standard of care therapy.
Overall, the time below ring, if you can say, it become like half.
Yes.
So earlier they were spending, that would be more important from my perspective. 20% was spent below range. Now it has become 10. And 6% was severe hypo and 3% it became.
So this is the graphical representation of the self-monitoring plasma glucose versus the CGM detected hypoglycemia, and we can see the hypoglycemic episodes were much lesser in the 2 to 4 weeks of duration in the first part of the study with a p-value of 0.0029. Now, in comparison with the adverse effect with dasiglucagon, there are incidences. There are incidences of some rashes, eczematous rashes was present, some episodes of upper respiratory tract infections, as well as the most common side effects were the vomiting, nausea, and diarrhea in the dasiglucagon group in comparison to the standard of care treatment. So they had concluded that dasiglucagon.
What is most important perspective from that regard? How many patients were you able to salvage from pancreatectomy? These will be the long-term questions. Like this 4 week, 8 week is just about getting the initial data in. But what we are interested in that, okay, you have a diazoxide refractory neonatal hyperinsulinism who is not a focal form. You are planning to post for surgery. Can we use dasiglucagon for a long time to prevent that? How was it administered?
It was administered by a subcutaneous infusion pump.
It's like
Actually,
an infusion pump only. So earlier we had the conventional glucagon and now we have got this glucagon. So the biggest question is whether you are able to salvage the pancreas in that setting, because many of these patients did not have had pancreatectomy by that time. So carry on.
So it has been concluded that dasiglucagon treatment has been associated with marked and clinically meaningful reductions in the all measures of hypoglycemia recorded by the CGM. They had also concluded why this CGM value has much more detection, because they had told that it is a way of intervention, that in SMPG we do not take 5 minutes of interval of blood glucose level and number of glucose. Though they have told that CGM value may not be that much comparable with SMPG, still it is better in picking up.
Many times you will pick up more, so that is the logical thing.
And
so what would you recommend?
Sir, it can be recommended considering the number of
so before you
decreasing the hypoglycemic
surgery,
yes,
this could be an option which should be definitely considered. Now, of course, you don't know how long will you treat.
Yes, and also there is adverse effects are not so much severe as we can see in the previous study, but here
because the adverse effects of pancreatectomy will be exocrine pancreatic insufficiency,
like
and
diabetes
deficiency that becomes too much.
So we conclude our study that it is a prospective randomized control trial with there is monitoring in terms of the blinded CGM that has been given to the patient, as well as unblinded self monitoring of plasma glucose. The population was taken as an infant between 3 to 12 months of age. So is it generalizable? Yes, it can be used in cases of infants with congenital hyperinsulinism, and this intervention is feasible. The limitations were in this study were that there is no standard care of treatment was advocated to the patient. That means there is no standard drug was given to the all patient of in this study. We have used multiple drugs as a standard of care, and also
because there is no standard of care.
Yes.
So in those cases, the standard of care is pancreatectomy. So they're trying to salvage. So of course, you can't say stop it. So this will be a problem in these trials.
And there is also the time and the frequency of SMPG that has been done. That is also a questionable thing, whether they had done in the proper time, they had done in the periods of the hypoglycemia was also questionable. Now the impact, so CGM detected hypoglycemic episodes were much improved in comparison to the standard of care in case of dasiglucagon treatment, and with a very minor adverse effect that is here used. The important thing in this study was the 30 among the 32 patient, 1 patient was further continued for the long-term extension of the study, and they had concluded when this study result will come, we'll get to know whether the long-term effect of the dasiglucagon is important in cases of congenital hyperinsulinism or not. So that's it.
I think this is a very, very interesting study. And this brings us to a very important fact that when you have established therapy, which is safe and effective, it is very difficult to replace it. So when you say, okay, we have got bisphosphonate, which has been used for 20 years in OI, I got this new agent, you just start using it, there will be a lot of resistance. You have got testosterone, which is safe, effective. So why would suddenly I start using aromatase inhibitors for induction? But here people are not comfortable with pancreatectomy as a primary modality. So even if you have something which has got certain side effects, they will prefer using it rather than going ahead with that from that regards. We'll quickly have a look at it, that if there are any questions there before we go ahead in terms of that. Dr. Randa is why is it risky to use aromatase inhibitors in females? So of course we don't use aromatase inhibitors in females because that will cause increased androgen level. So it will cause hyperandrogenism, which that's why we don't use it. And all these sessions will be available on the YouTube channel and our website course as well. So what we'll do now is that we'll quickly go through this. This is more of a conceptual rather than a study design. And it's this, Dr. Dhwani, you can discuss about the concept and what they did really in that way.
Thank you, sir. So moving on to the last study for the session today, is the use of adjuvant liraglutide and insulin versus insulin monotherapy in closed-loop hybrid systems in patients with type 1 diabetes. This study was published in the Journal of Diabetes Science and Technology in 2016. So again, as we know, type 1 diabetes is a common presentation in our clinical setup. It is defined by, or it is characterized by, a beta cell dysfunction, which is well known and which is the principal mode of treatment that is being followed. But what also happens and is often under addressed is alpha dysfunction happening in type 1 diabetes, which results in a blunted glucagon response to hypoglycemia and a postprandial hyperglucagonemia, which ends up causing a faster beta cell exhaustion. The most physiological mode of insulin delivery that is available to us now is the closed loop insulin pump, which takes care of the beta cell dysfunction in type 1 diabetes. However, frequent episodes of post-meal hypoglycemia and late hypoglycemia are seen even with insulin pump therapies, which needed to be addressed, and that is how the concept of using GLP-1 receptor analogs was considered. Previously, to address these issues, pramlintide, which is an amylin analog, was being used, but again, you need multiple subcutaneous injections of pramlintide. Then came up studies with exenatide, which was also a GLP receptor analog used twice daily. To reduce the frequency of injections, this study was conducted with liraglutide. So the ideal add-on therapy to insulin in the given scenario is something that will reduce your post-meal glycemic excursions, potentiate the action of insulin, reduce glucagon, is easy to use, and has, again, your ideal therapy should have minimal or no side effects. So the one meeting most of these criteria is your GLP-1 receptor analogs. The mechanism of action, if we look at it broadly, is that it increases your pancreatic insulin secretion, reduces glucagon secretion, uh, um, decreases gastric emptying, and increases your satiety levels, thereby restricting the amount of food intake. So the study was a randomized control trial, open label crossover, done in adults with type 1 diabetes of duration more than 1 year, who were on closed loop insulin delivery system. They had a fairly controlled diabetes with HbA1c of 8.5% at recruitment, had no anemia, weight greater than 50 kgs, no other comorbidities other than hypothyroidism per se, so no cardiac, renal, any other issues. They did include people who were on OC pills, antihypertensive, dyslipidemic, or antidepressant drugs. The exclusion criteria included adults who were pregnant or breastfeeding with underlying malabsorption syndromes and with history of alcohol or drug dependence. They also included subjects who were on therapies that might affect blood glucose levels or their measured values through CGM. So like people who were on paracetamol or vitamin C or steroids were excluded in the study. This was a short study, 24-hour study that was done, and patients were called on day 1 at 2 p.m. Yeah. And the study was started at 6:30. So their closed loop system started working at 6:30. The doses were decided by their insulin requirements in the last 3 to 7 days. Study A was the control group. wherein your only insulin pump was continued until the study period, that is next day 9 p.m. And study B received 8 p.m., that is just before dinner, they received dose of liraglutide 1.2 milligrams. And their insulin pumps continued as they would.
So liraglutide was a single dose or via a closed loop system?
Single subcutaneous dose.
They do mention it plus via anyway, so it was a single dose. The upper one they say insulin plus liraglutide via
Yeah,
closed loop.
and insulin via closed loop and liraglutide was a single 1.2 milligram dose. The study was designed to detect a 25% difference in mean area under curve of glucose for postprandial periods. And the sample size estimated was of 16 subjects in the study. So the study included 15 subjects, but the same subjects were crossed over. So 30 was the sample number eventually. It had, again, 5 males, 10 females. The average age was 26 plus minus 5.8 years. And it had no Asian population per se. The duration of diabetes was 14.7 plus minus 7 years with a mean HbA1c of 7.5, and these mean BMI again here was 26.4 plus minus 3. So more like overweight to obese category of individuals were included in this study. What they found was that the level of the blood sugars were lower, in especially
Prandial rise was lower.
prandial rise was lower with the liraglutide arm compared to the control arm. And even if you look at the mean area under the curve, it was statistically significant for the breakfast period and the lunch period between the two arms, with lower blood sugar levels in the liraglutide arm.
So liraglutide was given at what time? Night, evening.
8 p.m. the previous evening, and this is the next day, 3 meals.
So by that time the effect is gone. In the dinner.
Possibly
So
it
the
is.
next dinner.
Yeah, yes,
So
next
this is
dinner.
most likely explanation. You see a biggest impact on the breakfast,
Yes.
then you have the impact on lunch and then dinner. So probably it's going off. That's what they're saying. So if you give it as an infusion with that, that could also be a good option. But then the dose will vary. That will be a problem.
The secondary outcome looked at the insulin requirements, which were found to be lower with the liraglutide arm, and the glucagon levels, again, which were found to be lower with the liraglutide arm compared to the plain insulin infusion pump arm.
So basically what you're trying to say is that because you're giving a GLP-1 receptor analog, you have got a decreased gastric emptying. You've got lower amount of glucagon. That's why your postprandial rise is less. So which makes sense because now when we talk about giving basal insulin also, we are combining it with GLP-1 receptor analog. So these are the concepts we are coming up on that.
The GLP-1 receptor analog arm did tend to have side effects, especially in terms of nausea, GI symptoms, which was managed with ondansetron. The episodes of hypoglycemia were comparable in both arms, but not statistically significant, and there was no episode of severe hypoglycemia. But most of these hypoglycemic events were in the morning, and this was again probably due to the nighttime administration of GLP-1, and maybe switching it to the morning would have reduced the incidence of morning hypoglycemia and provided a more controlled glycemic profile at dinner time, where it was not found to be statistically significant in this short study. So while in the short 24-hour study, liraglutide was found to be statistically significant in terms of lowering the prandial glycemic variability and reducing insulin requirements. We might
more
need
likely which phase of study you will put it to?
preclinical.
So it's not really, it's more like a dose finding impact. This has to be a bigger study in terms of that, but it does hold promise in that regards. So thank you. So what it basically tells us is that if you have somebody who is overweight or obese, if definitely if somebody is obese, then adding GLP-1 receptor analogs will help. There are a lot of studies which have looked into the impact of GLP-1 receptor analog in type 1 diabetes. and they have shown that they do improve the weight predominantly by few kilograms with a mild impact on HbA1c. But this is a concept which is being studied in a better way, I would say, in this study. But this definitely needs more evaluation in terms of long-term use when you say everybody should get a GLP-1 receptor analog along with that. So Dr. Vikas is asking, do we stop basal insulin during the study? So this was an insulin pump. So there was no basal insulin there. So they were closed loop system. Um we can achieve post-prandial uremia proper bolusing. Do we need newer agents with pump as adjunct therapy? I think this is a novel concept. And so what they're trying to do is that somebody who's doing pretty well, they were all 7.5 was the mean HbA1c. Now the aim is they want to go below 6.5 or below 6. So that is a sort of a scenario. That's why they're talking about. So I would say if somebody is obese and somebody is having problems in terms of fasting, postprandial hyperglycemia. In that scenario, this could be an agent which may be considered, but this is not a sort of a significant primary agent in terms of treatment, and it's just an add-on to insulin in that scenarios. So I think we will close at that point of time. It was a very interesting discussion. We looked into 4 newer modalities of treatment. We talked about the impact of denosumab in the setting of osteogenesis imperfecta. We talked about GLP-1 receptor analogs as an add-on agent to type 1 diabetes. We did talk about the role of aromatase inhibitors for pubertal induction, as well as a novel glucagon analog for hyperinsulinism. So this is a way just to keep things that this is what may happen over the next 10 years or so. Many of these agents will fizzle out, some of them will come out. So this is how you need to look at the evidence. So I think we'll